Good day. It's Dr. Goldstein again. Um, Whatever time of day it is in your time zone, we're winding down our year of this year's clinical colloquium. So certainly until Professor Maki starts, you can put on your cameras would be great. Um, as you know, this is the clinical colloquium in menopause and midlife women's health for 2025. Next slide. So realize that this clinical colloquium is supported by the International Menopause Society's Endowment for Education and Research. Next slide. And today is really a very special treat. Dr. Pauline Maki, and her title for the talk today is Cognitive Changes at Menopause, a Clinician's Guide. But I need to tell you a little bit about Pauline, who's been a good friend for several decades. She's a professor of psychiatry, psychology, and obstetrics and gynecology at the University of Illinois in Chicago, in the US. For the past 25 years, she's led a program of NIH-funded research on menopause and its effects on mental and cognitive health. Her research addresses very important issues in women's health, such as how hormonal changes in menopausal symptoms affect women's cognition, their brain function, and mood at midlife, and the effect of menopausal hormone therapy on cognition and mood. She's a past president of the Menopause Society, formerly known as NAMS, and currently treasurer of the International Menopause Society. Her research has received very widespread recognition from advocacy groups, scientific organizations, the media, the government, including the offices of the Vice President of the United States, as well as Jill Biden when she was First Lady of the United States. And so without any further ado, I would ask Pauline to start to be able to share her screen and speak to us.
Thank you, Steve. Hi, everyone. Do me a favor. Can you put your name and your country in the chat so that I know where you're all from? I'd really appreciate knowing who you all are. That bio's just a little outdated. I'm secretary of the IMS now, but at any rate, it's good to be here with you. I'm going to be sharing with you some information on cognition at menopause. And let me just see a kind of raise of hands. How many of you, oh, we have a Liverpudlian. Hi, David, nice to meet you. I don't get to say that word very often, and it's one of my favorite words. So thanks so much. Okay, raise your hand if you see midlife women who have cognitive complaints. Like they say they have brain fog, right? Okay, and keep it up if you feel like you have a really good understanding of how to talk to them about this and what its causes are and how to treat it. Okay, so we have 2 people, maybe 3 people that feel like they know this. Okay, so my goal is that by the end of today, everybody's hands up, maybe both hands are up. That's the goal. And I'm going to draw on some of the work that I've had the pleasure of doing with my involvement with the IMS, and I'm going to give you some resources that are enduring. Please feel free to use these, and please share them with your colleagues. They include provider guidelines and patient guidelines. We're going to talk about menopause cognition in the brain. Here are my disclosures. So, you know, in the United States, this conversation about menopause was initiated when Susan Dominus from the New York Times in 2023 had this article, Women Have Been Misled About Menopause. And then we had just a flurry of commercials about hot flashes because Astellas's fezolinetant was approved. And some of the things that Susan described in this article had to do with the limited understanding and a lot of confusion about hormone therapy and dementia, and really just saying women deserve better. And I couldn't have agreed with her more, because what we're seeing now is both, it's a polarization. We're seeing on the one hand, these claims that the female brain eats itself. So I don't know how many of you saw the FDA announcement. Sorry to be laughing, But there was actually a social media influencer who said that the brain eats itself at menopause. And then we have other people who say nothing happens to the brain at menopause. Women can't get the answers that they need, so they go to Dr. Google, they go into the internet, and capitalism has plans for that empty space. So there's a lot of misinformation driven by the goal of making money in menopause. There's lots of good in femtech, there's a lot of bad in femtech. If you look specifically at the information about hormone therapy and dementia, it goes from hormone therapy is an anti-aging drug that you should use forever to taking hormone therapy for just a year may raise the risk of dementia. So how do we make sense of this mixed messaging, and how can we help patients? How can we have informed conversations with them about this confusing issue? Because when a woman experiences this brain fog, if she goes to the internet, she will see misinformation that this is an early sign of Alzheimer's disease. And talk about panicking women and doing a big disservice to women. So we must do better. So here are our 3 goals. So by the end of today's conversation, I hope that you understand what the epidemiology literature says about changes in cognition as women transition through the menopause. We're going to describe the changes in brain health that occur, and we're going to talk about how to counsel women on how to optimize their cognitive functioning. So let's talk about cognition and the perimenopause. So one big thing I want you to take home today is that the cognitive changes at menopause occur in the perimenopause. Okay, they don't initiate in the postmenopause. This is a menopause transition state. Now, here's the enduring resource that I had the great pleasure of working on with my dear friend and colleague, Dr. Nicole Jaff. It's called Brain Fog and Menopause, a Healthcare Professional's Guide for Decision-Making and Counseling on Cognition. And we did this for World Menopause Day. It's available in multiple languages for you. And we also have a very helpful, freely available patient handout that describes what is menopause brain fog, will it lead to dementia later in life, what role does menopausal hormone therapy play, and can I prevent or postpone dementia? I also wrote a very brief practice pearl with Nicole for the Menopause Journal. So this is the official journal of the Menopause Society. These practice pearls are also wonderful resources as we're trying to optimize our menopause provider skills. And it's usually 1 or 2 pages. They have these on a variety of different topics. So if you haven't accessed these practice pearls, you might want to consider that as well. Okay, so let's start with the question. Are cognitive changes a menopause symptom? And if you went to 1995, when the NIH had its big symposium, they would have told you no, but the answer now is clearly yes. So how do we know that something's a menopause symptom versus something that occurs with age? Well, there's really 3 ways that we can know this. One is we follow large groups of women as they transition from pre to peri to post-menopause, and we look to see whether independently of age, those symptoms increase in frequency or severity. That's one approach. The other 2 are more experimental. So you can give a GnRH analog like leuprolide, suppress ovarian hormone production, and see what occurs symptomatically with that acute pharmacological withdrawal of hormones. Or you can study what happens in surgical menopause. Okay. Now, the challenge with the GnRH analog in the surgical menopause is that we do not know if what we see in the context of acute estrogen withdrawal generalizes to natural menopause. And that's particularly true for the brain because, as I'll show you, it appears as though the brain does adapt to these changes in estrogen. So what we're going to do is to provide evidence that cognitive symptoms are in fact a symptom of menopause. So the first hint came from the study of women's health across the nation, about 8,000 women in their baseline study who were between the ages of 40 and 55, who fell into one of 5 categories, either early or late perimenopause, postmenopausal, or surgical, or all the women combined. And they just simply did a questionnaire looking at how many days in the past 2 weeks women had these symptoms. Now, you're going to hear a lot about hot flashes and swan and these other symptoms. I'll just say scientifically, their questionnaire for menopause symptoms is kind of weak, because it really does just ask how many days in the past 2 weeks have you had these symptoms, but it's still the best that we have. What I want to point out is the forgetfulness. Memory complaints are very common, about 43 to 45% of women. And if you look here in the red, as these hormonal fluctuations are initiating, you see that forgetfulness is the second most common complaint in the early perimenopause. The female brain, psychologically, mood-wise as well, does not like onset of hormonal fluctuations. If you look not at these subjective complaints of forgetfulness, but rather at objective cognitive tests, what do we see in these prospective studies? Well, we see that these cognitive changes are most evident on tests that measure what's called verbal learning and verbal memory. So verbal learning is what you're doing right now. So if you're listening to me, I'm speaking words to you, you are encoding them, and maybe, just maybe, when you see your patients, you will recall what I'm saying. Okay, that's verbal learning and verbal recall. And so that's a very important skill for daily life. We test this in the laboratory by giving women lists of words, like these here, and we have them learn this over 5 trials, and then we have them recall it later. And what we see is that declines in this cognitive ability are readily apparent beginning in the early perimenopause, right when we see those subjective complaints. And how reliable is this evidence? 5 of 6 longitudinal studies with thousands of women show this. That's how reliable and reproducible this finding is. It's very reliable. Now, they're not getting demented. They're just forgetting a few more words. Okay, now I'm going to show you evidence of causality. So on the left, we have what happens to verbal memory when a woman has her ovaries removed. And when you randomly assign women to go on estrogen versus a placebo for 2 months after that period of time. Now, this is the seminal study in my field, comes from 2019. This was an estradiol valerate injection, 10 milligrams. Okay, so here we have memory testing, and you see baseline women are doing just fine. And if they were randomized to receive estrogen, it maintains their memory performance. So we're hearing messaging. Women think that, oh, estrogen will boost my memory. There's no evidence of improved memory above baseline with estrogen. If anything, in the context of early surgical menopause, estrogen helps to maintain memory. This is the context right here, surgical menopause, where we do recommend uniformly, unless women have a contraindication, that they use estrogen until the typical age of menopause, which you want to do anyway for cardiovascular disease prevention, for depression, etc. Okay, so what we see here is a maintenance. If women were randomized to receive placebo, memory performance declined substantially and significantly. So this tells us that verbal memory is very sensitive to estrogen withdrawal, and that if you give estrogen back, it helps to maintain it. Now, this is when women were learning the verbal material, and this is when we forget things. So after 20 minutes, they couldn't remember as many of the words. But you see the same pattern of effects, that estrogen maintained their ability to recall that information over time. compared to placebo. So evidence of causality, same here. Here's a study that we did with a GnRH analog. This was both cognitive performance and brain functioning. This is before a GnRH, so we see verbal memory performance. Then, and you see areas of the brain in the prefrontal cortex that are involved in verbal memory. So what you're doing right now, here's a little nugget for you. If you successfully remember later what I'm telling you now, this is the area of your brain that's responsible for it, because this is the part of the brain that was working hard. Now, what happens under GnRH analog when women have been on that for a few weeks is that that area of the brain no longer is active and memory performance declines. However, after withdrawal, that area of the brain comes back online and this bounces back, okay? So we have longitudinal data showing that cognitive changes occur in the menopause transition independently of advancing age, evidence that when you suppress hormones with surgical menopause, if you will, if you have an acute withdrawal, memory declines, and we have evidence that if you give a GnRH analog, memory declines. So that's why we think quite clearly now that cognitive changes are indeed a symptom of menopause. Okay. Here are the data showing this reliable, reproducible evidence in thousands of women that we see declines in verbal learning, in verbal memory. Where you see in X, that study measured that type of cognitive process. Where you see purple means that the study showed that there was a decline in that area. So you see this reliable, reproducible evidence. I don't know if we have anyone from Taiwan or China here, but this is a study in Taiwan where language is pictorial. So it's not letter-based. And in those countries, interestingly, we don't see this decline. Are these permanent? We don't really know. If you look at SWAN, the study here, it suggests that these cognitive abilities bounce back. If you look at the Penn-Ovarian aging study, it suggests that verbal learning doesn't bounce back. So women continue to struggle a little bit with learning that word list, but they can recall what they learned with no problem in the postmenopause. 2 studies couldn't assess it. And then my study here, this last one, actually suggested that in women who have difficulty paying for necessities, who have a low socioeconomic status, so this is primarily Black and brown women living in poverty in the United States. In that population, it doesn't seem that memory performance bounces back. Why? My current hypothesis is a health equity issue. I don't think they get the care that they need for their menopause symptoms. So I'm going to show you links between menopause symptoms and cognitive dysfunction. Very important for your patients is that while cognitive symptoms do appear to be a real and common symptom of menopause, women are not dementing. Cognitive performance is maintained in the normal range for most women. And we estimate that anywhere between 8 to 10% of the most vulnerable women experience these changes that can persist into the postmenopause. And we're doing research to figure out why those women have these persistent cognitive changes. These are the vulnerable women, if you will. So this is 443 women. 2/3 of them had HIV. HIV did not make a difference whatsoever for cognitive performance. If you look at all women, regardless of whether they have HIV, you see here that there is this elevated probability of impairment. So this isn't just, I'm forgetting like 1/3 of a word. This is that you're performing a standard deviation below what you should be for your age and education. And you see this increase in impairment in learning and in memory, and to a lesser extent, attention. So we need to do better from a health equity standpoint about understanding the causes of cognitive dysfunction in this population of women. And again, my strong suspicion is that this has to do with untreated bothersome vasomotor symptoms, because this is primarily Black and Hispanic women who we know, and I hope who you know, have more severe and more persistent hot flashes compared to other women. And I'm going to show you research linking hot flashes to cognitive dysfunction. Now, raise your hand if you've heard an association between attention deficit disorder and cognitive performance. Have you heard this idea that women develop ADHD-like symptoms? So here's a gap. So your patients may say this, right? They may say, you know, I have this attention thing. We don't really know if this is real yet. We haven't done the studies, for example, where you follow women longitudinally with ADHD questionnaires over time, but my colleague Rebecca Thurston and I are doing that study now, but it'll take 5 years. You know, we won't know. But what we do know from beautiful work from Neil Epperson, who was just inducted into the National Academy of Medicine. Hurrah, she's amazing. She discovered that there is a substantial percentage of women who, if you give them an ADHD-like questionnaire, will meet criteria for ADHD, and they claim that it's new onset. And if you give them a stimulant, they do perform better on some cognitive tests. Now, I just published a study. No, sorry, I haven't published it yet. We have a revise and resubmit on a study in the Human Connectome Project that said that maybe about 10% of women show an attention-like phenotype, but the rest are verbal memory. Okay, so that's, I think, the closest that we have scientifically. So I do believe this is real. So while I still talk about verbal memory, because I do think it's the typical phenotype, I think some women do experience this attention deficit-like, but we need better science to advance that. So one of the most challenging things that you'll face as a clinician is dealing with women who are experiencing these changes in memory. And memory is what we think of when we think of as dementia, right? We think about Alzheimer's disease, we think about memory problems. So women are scared. And then they go onto the internet, and the internet just reinforces this obscene idea that they're dementing. And so, you know, if you can do anything for your patients, I think normalizing these cognitive changes and giving them perspective on them is super helpful. So what I say very simply, and you can tell me if this is helpful to you, is I say to women when they're like, oh, I think I'm getting Alzheimer's disease, I'll say, okay, if menopause caused Alzheimer's disease, then what percentage of women who are age 70 should be demented? And they say, well, 100%, because they all went through menopause. So it's not the menopause. It's not the loss of estrogen. I used to think it was the loss of estrogen. I think now that it's untreated menopause symptoms. So what you can say to them is this is a normal menopause symptom. The GnRH analog study suggests that it does bounce back. We don't have the best data yet, but you know, you can say your patients tell you that, you know, their brains are functioning better. That dementia at this age is very, very rare. Okay, that's how I counsel them about this matter. What about brain functioning? So I showed you reliable, reproducible evidence that memory performance declines in the transition from pre to perimenopause. Something has to be changing in the brain, right? But we don't know yet what that is. Why? Because unlike the cognitive studies, there are no longitudinal studies that follow women from the pre to peri to post menopause and measure their brain functioning. I'm leading one such study right now, and we presented some interesting data from that study at the Menopause Society, but literally December 2nd is when I get my first longitudinal data, and I've been doing this study for 7 years. So I'm really excited to see what we see, but generally I can tell you that what we're seeing in the brain is no difference in brain structure depending on whether a woman's pre, peri, or postmenopausal, but we see changes in the functioning of memory centers in the brain that my colleague Emily Jacobs has demonstrated normalize. Okay, so I'm going to show you the data for that. Okay, I could go on and on about the limitations of the current data. We're trying to do better. Mostly they're cross-sectional with limited sample sizes. Menopause stage is confounded with hormone therapy use. The studies, some of the ones that we hear about a lot, rightly focus on women who are at increased risk for Alzheimer's disease, but we don't know if that generalizes to the typical population of individuals. Okay, so here's the limited sample sizes of recent cross-sectional studies. You can see they're very small. What we want, of course, is the samples who transition from here to here, right? When those cognitive changes happen and you see that there's only about 30 women. So they're not optimally designed. They also have more of this genetic risk factor for Alzheimer's disease. A very important question scientifically, absolutely. But what we're finding and what others are finding is that whether a woman has this risk factor seems to matter. What my science is showing uniformly, regardless of where I probe it, I'm finding that women who carry this risk factor do not benefit from estrogen, which is interesting. We've heard hypotheses about the brain changing its source of fuel. This is an hypothesis that's being tested right now. And there's an alternative hypothesis, or maybe even a complementary hypothesis, that the wiring of the brain changes when estrogen levels drop and that it rewires. And it's that hypothesis that my work aligns with. So I'm leading a study in pink here. This is the one that I'm finally getting my longitudinal data on, where we will have, 80 to 90 women in each group, and we're following them longitudinally. So this is our attempt to do better by women. Keep posted. So how do you counsel patients? So your role as a menopause clinician is to effectively treat the menopause symptoms that drive some of these cognitive changes, and to advise your patients on other ways that they can optimize their brain health. So we're going to talk about how mood, sleep, and vasomotor symptoms affect cognitive performance. So let's start with hot flashes. You may have seen that there are 4 distinct trajectories of vasomotor symptoms. So one of the most misleading ideas is that hot flashes, they only come on at the time of menopause. So you hear some influencers saying, oh, if a woman tells me she has hot flashes, I know she's in menopause, which is just against all of the data. Because if you look at the SWAN, you see that the probability of hot flashes is actually high in these, in at least 2 different, if you will, clusters of women, including, so 25% of women have hot flashes consistently. These tend to be Black women, tend to be women with elevated depression and anxiety symptoms. And I'll tell you that studies using objective monitors have validated that these do occur in the premenopause. Early onset, this is about 18% of women, so it's 35% of women that you see these hot flashes. Okay, but this is what we typically think, right? For women who are symptomatic, this green trajectory here, this is what we think of as the typical kind of menopause. That's the late onset, 29% of women. And then there are the lucky 27% of women who maybe have some mild hot flashes. The point I want to make is that this is the final menstrual period here. And my sense is that the cognitive issues either resolve or not depending on a woman's experience of her menopause symptoms and whether they're treated. So we measure hot flashes objectively using ambulatory skin conductance monitors that measure electrodermal activity. So that's just sweating on the surface of the skin. Swan has demonstrated that frequent vasomotor symptoms persist on average 7.4 years, 8.9 years if a woman is Latina, and 10 years if she is African American. Susan Davis's group has shown that 33% of women have severe vasomotor symptoms more than 10 years after menopause. So that means that occasionally they will have at least a severe one. And we see when we monitor women who are in their 60s, we see these hot flashes. So each of these is a hot flash. And this is a woman having 37 physiological hot flashes in 24 hours. Our most recent work done by my graduate student, Dr. Alexandra Page-Blanc, for her dissertation, demonstrated that in a sample of Black and brown women who are saying that they're bothered by their hot flashes and who enrolled in our study, many of them working at my hospital, those women on average, had 27 hot flashes a day. So these are very common. And when a woman has a hot flash, she has a surge in cortisol. And cortisol is bad for the hippocampus and it's bad for the prefrontal cortex. We find that when you measure these hot flashes using ambulatory monitors, they are associated with frequent hot flashes, are associated with declines in verbal memory, Alzheimer's disease biomarkers in the blood, alterations in memory circuitry. This is the hippocampus. So if you're listening to me right now, in addition to your prefrontal cortex, this is probably lighting up. And tiny stroke-like lesions, white matter lesions in the brain. The more hot flashes that we have, the more we're seeing these. Now, is this causal? There's a proof of concept study using a non-hormonal intervention for vasomotor symptoms called stellate ganglion blockade. Now, stellate ganglion blockade involves an injection of the anesthetic bupivacaine into the C6 ganglion. And when we compare that to a sham, so a subdural saline injection, you see that this non-hormonal intervention does meet the FDA criteria for reducing moderate to severe vasomotor symptoms. So these are the number of counts, and you see that one injection really leads to persistent benefits. Now, what we're interested in is looking at whether treatment with that SGB intervention led to improvements in memory. And what we found is that memory bounced back in direct proportion to the improvement in vasomotor symptoms. So this is the first proof of concept that if you treat hot flashes, even if it's with a non-hormonal intervention, you can improve memory, and that the magnitude of improvement in memory aligns with the magnitude of improvement in hot flashes. Okay, so now let's get into hormone therapy. So the IMS, the TMS got together and had a revised global consensus statement about menopausal hormone therapy, saying it's the most effective treatment for vasomotor symptoms associated with menopause at any age, but the benefits are more likely to outweigh risks if initiated for symptomatic women before the age of 60 years or within 10 years after menopause. Okay, so societies do endorse its use for the treatment of hot flashes. We know that we have these FDA approved prescriptions, and now in addition to fezolinetant, we have the dual neurokinin receptor antagonist, NK3, NK1 antagonist, elinzanetant, and there are off-label prescription therapies too. So there are a variety of different things we can offer patients with vasomotor symptoms. I also want to note that hormonal contraception can be used as hormone therapy in those women who do have hot flashes in the perimenopause. In low dose oral contraceptives have higher hormone levels, meaning estrogen and progesterone, than hormone therapy. And they effectively decrease the variability in estrogen that's associated with some of the most bothersome symptoms of the perimenopause. Some providers continue this contraception until the typical age of menopause or into the mid-50s when women reach menopause. So 90% reach menopause by age 55 years. Okay, so you could use any one of those. What about mood? So about 45 to 70% of perimenopausal women report a worsening of mood, not necessarily clinical depression, but a worsening of mood. This is compared to 25 to 30% of premenopausal women. And 3 very large studies document increased risk for depressive symptoms in the menopause transition. So like cognitive performance, mood is a menopause symptom, so poor mood. We and others have demonstrated that even mild symptoms of depression are linked to objective memory problems at midlife. And here are just a few of the studies that have demonstrated that. So treating depression is likely to result in an improvement in memory. What about clinical depression? About 5.1 out of, if I were to take a snapshot of 100 premenopausal women right now, 5.1% of premenopausal women would have clinical depression, compared to 9.1% of perimenopausal women and 9.8% of postmenopausal women. So this is, in fact, a symptom that worsens in the perimenopause and persists. Again, persistent mood problems might explain why some women continue to have cognitive issues as they transition through the menopause, whereas women who experience transient mood problems may, in fact, recover. So there are 5 general contributors to major depressive disorder at menopause, and I want to go through with you how to treat it, so that if your patient has clinical depression, when you effectively treat it, their memory performance would also benefit. So women with premature menopause are in fact at increased risk for depressive symptoms. Surprisingly, the evidence that replacing with hormone therapy would treat this is not strong at all. It's a surprise if you look scientifically at this. We know we need to use estrogen in this group according to the ESHRE guidelines, but it doesn't seem sufficient to treat major depressive disorder. Probably does for just worsening depressive symptoms that are in the normal range, but not for major depression. So for that group, if you have a patient with premature menopause to treat their mood problems, their clinical depression, we use antidepressants. Women with a history of depression who are now coming to your clinic and have major depression again, that will happen to 59% of your patients with clinical depression histories. So it's really important to monitor those patients. You want to treat with antidepressants. Why? Because that's a recurrence of a pre-existing disorder. Some of your patients have a depression because of menopause, because they are sensitive to estrogen withdrawal. Now, who are those women? It probably tracks with women whose moods declined perimenstrually, whose moods declined in the postpartum period. And for those women, the goal is to treat with estrogen if they're perimenopausal, because it's the period of estrogen withdrawal. Now, for those patients, if their mood is effectively treated with estrogen, and now they're postmenopausal, when you withdraw that estrogen, they are very likely to have a recurrence of their major depression. So it's very important to monitor those women. Women with bothersome vasomotor symptoms and related sleep problems, You want to treat their hot flashes. It can be with an effective non-hormonal. My preference is the neurokinin targeted therapies or hormonal hot flash intervention. Many of your patients will have depressive symptoms because they're going through major life transitions, children leaving the home, divorce, new onset of illness, parents' death, those kinds of things. For that, you want to prescribe psychotherapy. You want counseling. Cognitive behavioral therapy is the way to go. For subclinical depression, so let's say your patients don't have depression, but they have a worsening of their depressive symptoms, they can get psychotherapy, especially cognitive behavioral therapy, and this is available through the cell phone as well. Engaging, prescribing physical activity in randomized clinical trials is a very effective treatment for subclinical depression, and actually in some studies, actually for clinical depression. For women whose depression is related to high stress, mindfulness-based Tai Chi Chuan is evidence-based, and mindfulness-based stress reduction is as well, in yoga. These are all randomized trial-based recommendations. What about sleep? So you don't need me to tell you that if you haven't slept well, your cognitive performance isn't going to be great. But let's go through just the sleep data. The major phenotype, the major presentation clinically of sleep problems is awakenings. So these increase from about 25% of women in the premenopause saying that they have disruptive awakenings up to 40% in the late perimenopause. This continues. And women with surgical menopause have even worse sleep. So this awakenings is generally the phenotype of menopause. Now, many of the waking episodes, 1/3 of the wakening episodes have to do with hot flashes on average. So if you look at whether women wake up, here's the time that a woman had an objective hot flash. You can see that there are awakenings clustered around that hot flash. So that 78% of the time that a woman has a hot flash, she wakes up. Now that might make you think that most of the wake time has to do with hot flashes, but that's not the case. Studies by Fiona Baker's group shows that 2/3 of the time a woman is awake, it has nothing to do with a hot flash. Okay, so there's some rewiring of the brain. I don't have time to go into it now, but the current thinking is that it probably has something to do with the neurokinin 1 receptor and substance P in the hypothalamus. And that may be very well why women who are randomized to elinzanetant have significantly better objective and subjective sleep compared to women who are randomized to receive placebo, because that elinzanetant is, it blocks substance P on that neurokinin 1 receptor. When we give substance P to young men, it disrupts their sleep. So it makes sense that if you block that neurokinin 1 receptor with elinzanetant, sleep improves. So as you might imagine, we're very interested in whether elinzanetant improves cognition by improving sleep, and also interested in whether fezolinetant improves cognition by improving sleep. Now, how do you treat your patient's sleep disorder? Because again, treating sleep problems improves cognitive function. Well, the first line treatment is cognitive behavioral therapy for insomnia. It's a behavioral intervention. The academies of sleep medicine uniformly say this is how you treat sleep disturbance. In the United States, this is available through freely on an app through the Veterans Administration. So this is what we recommend. You can also refer your patients to ICBT practitioner. They're hard to find. So these online CBTIs are really helpful. Now, some clinicians are tempted to use sedative hypnotics, the Z drugs. They're helpful for insomnia disorder, but They can be addictive. Women can become dependent on them. And paradoxically, it can do the opposite to their cognitive function. So we don't recommend, and nor does the European Sleep Society recommend using sedative hypnotics for an extended period of time. What about hormone therapy? It appears from meta-analyses that hormone therapy improves sleep in women who have hot flashes, but it doesn't improve sleep in women otherwise. That's the main takeaway from the meta-analyses. Some women do find relief from the use of a nighttime progesterone tablet. I happen to be one of those women. I've done an ABA design where I take the progesterone, measure my sleep objectively, don't take it, etc. And I can see that my brain likes a little bit of progesterone at night. This is probably an individual difference phenomenon. It's 100 milligrams of micronized progesterone. Some studies have gone all the way up to 300 milligrams, surprisingly without mental health repercussions, but at any rate, it's something some people like to try. There is some evidence that in the perimenopause, transdermal estrogen can be helpful. So in the perimenopause, that might be helpful. And that effect is independent of vasomotor symptoms. Here, I'm showing you what non-pharmacological or what interventions that are non-hormonal, what effects they have on insomnia symptoms from the MIS-FLASH trials. So these are large clinical trials funded by the NIH. And you can see here that the most effective treatment is CBTI. This is how effective it is compared to an SSRI, and venlafaxine was significantly associated with improved sleep, but nowhere near as much as CBTI. Exercise is also highly effective, provided that it's done early in the day and not close to bedtime. Yoga is effective, and escitalopram is borderline. Omega-3, interestingly, tended to decrease sleep. We don't understand why that is, but estradiol, this is a low dose estradiol, didn't help. So really this shows that CBTI is the clear winner here. Look at that effect size. In fact, CBTI has an effect size of 1. So that means that you get a full standard deviation improvement in sleep with CBTI. Okay, what about hormone therapy and cognition to close? This is the take-home message. So younger women who go through menopause early, who are given estrogen alone, just like that study I showed you earlier, they do benefit. And this is when we should be giving women hormone therapy. Otherwise, it's neutral for cognition, depending on, regardless of age. The exception being that if you use medroxyprogesterone acetate as the progestin, then memory performance declines, okay? Otherwise, it's neutral. So it's neutral if you use oral estradiol plus vaginal progesterone. This is neutral effects of estrogen plus progestogen with oral estradiol, transdermal estradiol, conjugated equine estrogen. So that's the take-home message. These are the 4 studies in this box. So just to show you how reliable and reproducible this is my initial study, 180 women followed by for 4 months, no effects on cognition. Then we had the Whimsy study from the WHI showing neutral effects in 1,326 women followed for 7.2 years on either of these formulations. And we had the KEEP study with a patch or conjugated equine estrogen plus cyclic micronized progesterone. That was neutral in almost 700 women. Then we had ELITE, that was oral estradiol with vaginal progesterone, 234 women, fewer than 6 years since the final menstrual period, who were followed for 4 years. Neutral, 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 neutral. Now, all of those women in those clinical studies did not have vasomotor symptoms because We and others wanted to know if hormone therapy was beneficial for cognition if you didn't have symptoms. In other words, is it an anti-brain aging drug? And the answer seemed to be no. We also don't know if hormone therapy benefits cognition if it's given in the perimenopause. Now that's important because that's when the changes occur. And then I'll close with hormone therapy and dementia. What used to be the black box warning for hormone therapy and dementia came from this study, the Women's Health Initiative Memory Study, where they looked at all-cause dementia in women who were age 65 years and older when they were randomized to receive hormone therapy. And in that setting, hormone therapy doubled the risk of dementia. So twice as many women. In the conjugated equine estrogen alone arm, the findings were neutral for all-cause dementia. So this is the initial findings from that WIMS study, which was a study from the WHI. Very different data emerged with the WHI hormone therapy study. So this is death from Alzheimer's disease, an outcome that they could study in all 27,000 plus women in the WHI. Again, this is looking at women who are age 65 years and older. In that long-term follow-up, so this is the 18-year follow-up data, conjugated equine estrogen plus medroxyprogesterone acetate was neutral, and conjugated equine estrogen, wow, it was associated with 26% reduced risk of dying from Alzheimer's disease. So that sounds interesting and maybe beneficial for clinical practice. However, if you look at the number of women needed to treat to prevent one case of dementia, it was 2004. So you'd have to treat, so 2003 women would get no benefit. And then when you treated your 2004 patient, that patient would get a reduced risk of dying from dementia. So it just doesn't make sense to treat for that reason. If you look at the earlier study, the number needed to harm with CEE-MPA is 436. That's where you get the doubling of the risk of all-cause dementia. So, so the goal here is not to use hormone therapy to treat or prevent dementia. Now, recent observational studies also do not support the use of menopausal hormone therapy. This is true in 84,000 women in Finland, more than 118,000 women in the United Kingdom, 105,000 women in Taiwan, and 61,000 women in Denmark. And importantly, they find these, that risk was evident in women who initiated hormone therapy before age 55. And some people think that this was a time when women who were at increased risk for dementia started using hormone therapy for that purpose. So maybe that explains it. But at any rate, it's a real but rare risk. It's a real but rare risk. In Finland, it was 9% increased risk for estrogen therapy alone and 17% for EPT. And again, this was particularly true for women who are less than 60 years of age. Now, the one setting in which prevent Alzheimer's disease is in women who are surgically menopausal, where removal of the ovaries before age 48 increases the risk of Alzheimer's disease or cognitive impairment by 70%, and the use of estrogen therapy until the typical age of menopause completely offsets that risk. So that's the setting. Again, early menopause is when we use hormone therapy for cognitive prevention. And this is what supports the North American Menopause Society guidelines, which essentially say that hormone therapy is not recommended at any age to prevent or treat a decline in cognitive function or dementia. That if you use this particular formulation in older women, you can get an increase in dementia, but that estrogen therapy may have cognitive benefits when initiated immediately after hysterectomy with bilateral oophorectomy. but hormone therapy in the early natural postmenopause period has neutral effects. So what do you tell your patients? Final slide. Heart health is brain health. So you want to help them to optimize their heart health by telling them that their brain health depends on their heart. You want to encourage them to maintain an active lifestyle with 150 minutes of moderate intensity aerobic physical activity weekly. You want to encourage them to have a healthy body mass index, to avoid smoking, avoid alcohol intake, avoid brain injuries, to stay connected, engage socially, especially if they have a history of depression, and to exercise their brain, to learn a new skill, learn a new language, do something that's cognitively hard. And this is based on recommendations from the WHO and Lancet based on very solid evidence. Okay, so in conclusion, there's reliable evidence that verbal learning and memory decline in the perimenopause. We don't yet have longitudinal neuroimaging studies to understand what the corresponding changes are in the brain. Our clinical recommendations are to treat menopause symptoms that may be contributing to cognitive issues, including vasomotor symptoms, sleep disturbance, and low mood. And in women with no or low vasomotor symptoms, there is reliable evidence of neutral effects of hormone therapy on cognition in the early menopause. There are no clinical trials of hormone therapy on cognition in women with bothersome vasomotor symptoms. In theory, hormone therapy could improve cognition in women with bothersome vasomotor symptoms, given preliminary evidence that a non-hormonal vasomotor treatment enhanced cognition. And with that, I will stop and I will take your question.
Thank you very much, Pauline. That was just outstanding. I'll start with a question of my own. And, you did a beautiful job of showing us the relationship between vasomotor symptoms and cognition, verbal memory. And I'm a clinician, okay? In other words, you're looking at large groups of people. I see people one at a time. One of the problems that I seem to have with SWAN is this concept of the early and late perimenopause, because not everybody's ovaries seem to have read that paper. There seem to be people who float between, 60 days between bleeds, and then they'll have 3 months of bleeding twice a month. So, and
Yeah.
I'm always wondering because so many people will have vasomotor symptoms, which then go away, and then they'll have 2 or 3 months of bleeding, as opposed to truly menopausal patient who's consistent. So I'm curious to know, you've done so much work with objectifying hot flashes, especially in women who are not yet have dead ovaries, so to speak.
Yes.
How long does it take? Is it the delta estrogen, or how long does it take for, if you look at the mechanism of action of the NK3 and this concept of the balance of estrogen in the candy neuron, how much drop in estradiol endogenous do you need to get some hot flashes? And then, how much intermittentness did you see in your objective studies? And,
So studies have looked at that, and they haven't been able to find a clear association between estrogen levels and hot flashes, or in change in estrogen levels and hot flashes. But the problem, Steve, is that these are studies that were done in 1990, early 2000s, when you had a one-shot measure of estradiol, right? So how do you really know if your sample? We know that you shouldn't take one shot of estradiol and generalize to what a woman's hormonal milieu is. So funny you should say that. I'm just dropping in a grant proposal where we measure estradiol every day and measure objective hot flashes every day. So we'll see. We'll see. But we have so many women who have hot flashes before the final menstrual period, and then they just worsen. I think the main thing is just to believe women. And when they tell you that they're having these bothersome vasomotor symptoms, just treat them. Don't overthink them. Just treat the hot flashes and say to them, it's likely that cognition may very well improve for you. And when you come back, let's talk about that.
And that's
And
probably
then
why if there are no contraindications and you have the slide, tend to like low-dose birth control pills, mainly
yeah,
because of the control of any irregular bleeding.
yes,
Because if you put
yes,
on that estradiol patch in the
yeah,
perimenopausal woman, it just makes the bleeding worse. And I get the bleeding. Uh,
yeah. And I will
that's-
say, Steve, I don't talk about it often. Maybe I should. I have published a study in premenopausal women where I measured their verbal memory when they were on their dummy pills and when they were on their active pills, and their verbal memory improves. So
on
I think
on the active pills.
on the active
Yeah,
pills. So
that's
I think we should do a monotherapy, never
always.
withdraw them. And that data suggests to me that maybe the oral contraceptives will be beneficial. And Swan also had some data to suggest that women who are on oral contraceptives or hormone therapy in an observational study did better.
And since I have some women whose husbands had vasectomies who are using birth control pills, I like to call it hormonal cycle control
There
as
you
opposed
go.
to
Very
contraception.
good. Very
And
good.
always give
Yeah,
it continuously because that withdrawal,
always.
there's no point if you're using it
No.
for this purpose.
No,
Feel
and
free to
you and I have
unmute.
talked, the oral contraceptives are grossly underutilized in the perimenopause and can bring women mood relief, bleeding relief, sleep relief, because perimenstrually we have sleep problems as women. So it can be a very effective treatment, but you just have to tell women why you're using oral contraceptives and not
Right.
hormone therapy, because otherwise they feel dismissed.
Well, and I
You have to
find
explain that you're suppressing her.
too many new people to the field are using HRT. Patients who are perimenopausal want HRT, and they don't realize that the concept here is suppression and
Suppression,
substitution, not replacement. Feel free
100%.
to unmute, raise your hand, jump right in. We've got at least 6 more minutes. I promised people a hard stop at 15 after.
Look
So
at across the globe, all of these wonderful places.
look home, raise your hand, go
Lithuania,
ahead, unmute.
Nigeria, Turkey, Hungary, Australia, Canada, UK, Qatar, India, and Liverpool.
Home and
Wow,
then
it's
Gina.
amazing.
Dr. Maki, thank you so much for this really very, very interesting talk and very relevant. So many patients bring up this symptom. I was wondering specifically about treating sleep. You haven't mentioned the DORA category of sleep treatment. I was wondering what your thoughts were on those.
So Dora, sorry, do you mean the rexogenic categories?
Yeah, like the Kivivik, I think is what we call it in Canada.
Yeah, yeah. So if you look at the European Academy for Sleep Medicine, they don't recommend long-term use of that category of sleep medicines because of the side effect profiles that women can have with them. My philosophy about this is that if CBTI should be the first, because sleep is a habit. You can train your brain to sleep. Honestly, you can. It's something that we can train our brains to do. We just have to instantiate that circadian rhythm. However, not all women can do that, particularly if they were never good sleepers, right? And in that case, I think pharmacological interventions and the orexigenic interventions are probably the way to go because they don't have that addictive propensity that other drugs do. It could be a bridge treatment for those women. Maybe they do it during menopause and then kind of withdrawal. I think my strong suspicion, though I'm going to be very clear, we do not yet have the randomized trial data to support that, is that elinzanetan's NK1 mechanism of action. My strong suspicion is that it will very well work even in women without vasomotor symptoms. So I think that's the menopause mechanism of sleep problems. And we need that trial. But what we're seeing with elinzanetant is if you look in the trials at the women who had the fewer hot flashes, they still got the sleep benefit. And that's the data I think that we have. And there's also objective sleep data that we've presented at meetings. So, you know,
So there might be an indication for sleep disturbance on itself with or without vasomotor symptoms
I
eventually.
think there may be if they decide to do that trial. But I don't know yet if this is specific for midlife women because their sleep disturbance is related to alterations in neurokinin signaling, right? So we have this overactivity of the NK3 receptor, and that's what's related to hot flashes. That's why that area of the hypothalamus enlarges at midlife in women because there's overactivity of the NK3 receptor when estrogen is withdrawn. So I think we don't know how that NK3 works on NK1 and what that communication is between those signals because neurokinins are autoregulators. They're paracrine related mechanisms. And I think that that system is very complex, but it may very well be specific to midlife women rather than to men, but who knows? We'll have to see.
Thank you.
Gina, unmute and ask your question.
Hello, thank you for the lecture. I would like to ask about testosterone therapy for brain fog, for mood, for better mood, because many patients are asking for this testosterone therapy. They found in social media this. And what is your opinion?
Oh, it's so hard. Yeah, testosterone is everywhere in social media in a data-free zone. In meaning there is data. People have looked at this. It doesn't do anything to cognition. There's a tiny signal for spatial cognition. Maybe it improves spatial cognition a little bit in women, but that's not nowhere near as reliable and reproducible as that verbal memory thing that I've shown you. It's just a data-free space. And the testosterone in sleep, there's not a strong signal there for men or for women because I don't think it targets that pathway, you know, that hypothalamic pathway that we think is probably involved. The other complicating thing about sleep in women is that when women wake up, they ruminate. They start thinking about everything they have to do the next day. And their sleep, their awakenings persist. So that's why a CBTI-like therapy where you train women, okay, don't do that, and they practice and they turn that off, they spend less time awake. And, you know, so it's very complicated and multidimensional.
Great. Well, I really want to thank Dr. Maki for an amazing talk. And we've got some slides that before you go, I'd ask Marion to put those slides back up. Yes. So, you know, all of you should be aware of the things that the IMS does, the clinical colloquium here in the bottom left. Obviously, you're aware of our 20th World Congress will be in Rio starting September 30th. I hope you all can come. Some of the past clinical colloquium groups, when they've been there, have made attempts to actually get together and meet as a class. We've got World Menopause Day, the journal Climacteric. Menopause Info is for consumers in various different languages. If you haven't taken Impart, it's a wonderful educational resource. We have webinars, interview series, and what's near and dear to my heart, CAMS, the Council of Affiliated Menopause Societies. Hopefully you all are involved in your local societies and they're part of our umbrella. And you are, you know, if you're not involved in your local society, get involved in your local society. We're allowing different societies the ability to run a webinar under the auspices of what we call the Menopause Hour. Next slide. If there is a next slide, yes. So some of the exclusive offers for IMS members. If you do Impart, you get a free 1-year IMS membership. You can do a partnership with a reduction in cost through your local or regional societies that are members of CAMS. And we just mentioned that there's tons of monthly live events, an extensive library of educational resources available. So Hopefully you're members of IMS at some level. It's very affordable, and if not, help spread the word. And finally, save the date. Make every attempt you can if you can come to Rio on September 30th for the 20th World Congress. It's going to be jam-packed with great information. And with that, I would thank you all, and I will see you next month, because next month is our last colloquium, and I actually will be presenting to you. I believe the title I gave it is Ultrasound in Midlife Women, Whether You Do It or You Order It. So
I just put the 2 resources from the IMS on brain fog in the chat, everyone. One for patients and one for providers. Those are the free links. So thanks. And yes, let's see you in Rio.
Yep. Have a great day,
All
everybody,
right.
or
Be
night.
well.
Take care. Bye-bye.